we have a very, very exciting all-female panel of public health experts. I am really thrilled to be about to introduce you to them. Let me please introduce the chair and invite her up here. Samia Liaquat Khan has worked in the international human rights and development sector for over 20 years with a focus on program design, implementation, monitoring and evaluation, including at the Pakistan Poverty Alleviation Fund and Tabad Lab. She's currently CEO of QAISEN Pvt Ltd. Samia, may I invite you to come up, please?
Thank you, Rabia, for introducing me, and thank you everyone for being here. I have two really fantastic panelists, and I have seen their work, and I'm really impressed by what they do and what they have been doing. So I would first like to introduce Dr. Shabana Haider. She is the country director of ThinkWell Global, which is an international organization providing technical advisory services to 3 provincial governments on health financing and health system strengthening. She is also the chairperson of the Board of Governors of the KP Health Foundation and leading public-private partnerships in the province. She has formerly been the chair of the Advisory Committee to Health and Population with the Planning Commission of Pakistan and also a member of the Planning Board. Welcome, Dr. Shabana. My second panelist is Dr. Maryam Mustafa. She's assistant professor at the Syed Babar Ali School of Science and Engineering here at LUMS. Her research interests are human-computer interaction, mixed realities, and information communication technologies for development. Her work is interdisciplinary in nature and draws from cognitive sciences, human perception, sociology, and anthropology to inform the design of ICT interventions. And more recently, her work has focused on gender design of technologies to promote equitable access for women in Pakistan. Welcome, Maryam. So, this panel is on public health and governance. And before I go into asking questions, I'm going to sort of give a little bit of an overview of what we in Pakistan are facing today. So Pakistan's health statistics read very poorly, right? Maternal mortality is 186 per 100,000 births. Drilling down to provincial levels, I think Balochistan has nearly double the maternal mortality rate of that of the national level. In 2020, Pakistan ranked third among the top 10 nations with the highest infant and maternal mortality rates. That's saying something, right? In terms of family planning, we all hear that there is a very high unmet need, 17%. But according to a recent Population Council report, annually there are 3 million abortions taking place. And these are not like on the sly abortions. These are families coming together, husbands and wives coming together and deciding that they cannot deal with looking after another child for whatever reasons, and the high number of abortions is basically linked to the fact that access to a preventive reproductive medicine is not readily available. We all know polio has not yet been eradicated. We just heard, I think there's over 55 cases of polio currently, the last 2 being discovered just very, very recently in the last 10 days. And immunization rates vary depending on provinces and districts. I know the expanded program on immunization is still trying to sort of, get its figures met. Of course, again, when you look at the provincial disparities, Punjab is much higher in terms of immunization rates than the other provinces. The public health system faces a number of challenges, including shortages of infrastructure, of medicines, of medical equipment, and of qualified healthcare professionals. According to data, Pakistan spends $38 per capita on healthcare, and that's pretty low and lower than a lot of other countries in the region or other developing countries across the world. India, for example, spends $57. Ghana is like $85 per capita. Over the years, of course, there have been some programs implemented under the public health sector which have shown some great success. I talk about the Lady Health Workers Program that was started in the early 90s. It's still continuing today, and I'm going to be asking Dr. Shabana a lot about that. It had some very good success, but then in the last 10 years, the results coming forth have not been as good. And so if impacts are not being sustained, where do we need to go? There's also the Sehat Suhulat program that was recently undertaken, and this is more about, health insurance and sort of providing healthcare to everyone, health for all in a way. And then finally, we now as a country face huge impacts of climate change. And this is the reality that has embedded itself and will have a huge, significant impact on the ability and capability of the state to be providing adequate health services, be it preventive, primary, or addressing sort of, when disasters happen, the human needs when disasters happen. And yet, surprisingly, during the COVID pandemic, Pakistan, we were one of the best, I think, that managed that. So we seem to have a sort of an up and down situation here. And I want to go now back into my questions and starting with Dr. Shabana. Um, sorry. Before I drill down, first of all, I just want to ask you in terms of what you see as the critical health challenges that are facing Pakistan today, and what is the public health system? How has it been set up, and do you think that it is able to address these challenges?
Bismillahirrahmanirrahim. Thank you, Samia, for the kind introduction, and thank you for being a great audience. So, just to start with, we have multiple challenges in Pakistan related to health and population. I call this the H&P sector, where health, nutrition, and population. I count it one because nutrition and population are equally important and as a part of the health ecosystem. So starting when we see health, we look at 6 building blocks under the WHO's framework, which is more related to governance, which is related to health financing, medical and supplies, HR, data systems, etc. So if I start from governance, we are in a dismal state, as you said. I'll give you much more indicators related to it. We are the third in the world with the largest stunted children in the world. So even if you do anything under the sun, if you're not able to raise the IQ of those 1,000 days, you are where you are. So you know about polio. So our population, coming to the population, I'll just give you an example. Our population is equal to 60 Singapore, 60 Dubais, and 40 Singapores. And even if you try to build up an infrastructural system that is big, and even if your GDP, which is related to your health financing, even if that improves, you're not able to cater to everything. So I think one of the biggest challenges for me right now is nutrition and population. Coming back to health. So we are marked by various challenges. We have a governance that is very archaic, ancient, and the way it's running, it's very personnel driven. It is not systems driven. I'm a health systems practitioner. I'm not a researcher or an academia. I see on the field, and I am reporting what I see in the field over the career of my 15 years. Working with the government, also having a government hat, and now as an international leading an international organization in the country. So governance, any province, even after the devolution that happened in a hurry, the local government ordinance. So we were not ready to be devolved at that time. But looking back now, yes, we have improved capacities in the provinces, but the provinces are not doing well. So there are governance challenges, and we can deep dive into them. The health financing thing. So health financing indicators, you said 38, the new NHA says $43 if it's improved, but that's the per capita spend. But if you try to unpack the $43, how much does the government spend? The government spends $12.5, which is equivalent to like 3,500 rupees per year per person. The rest of the money is paid out of pocket. So almost 50% of your expenses on health, you cater to you yourself. So huge high out of pockets. What about catastrophic health expenditures? Your catastrophic health expenditures vary between 4 to 5%. So roughly about 73 million people, are they have to undergo these catastrophic health expenditures, which means that more than 10% of your income of the household goes to health. So that's about a little bit about health financing, and we can go into details as we deep dive. I'm just trying to, frame what we're talking about. So medicines and supplies. Medicines is an important operational cost, and one of the things that drives the patients to the hospital is medicines. That's what we've seen in rural areas. It's one of the primary drivers that, a doctor is available, the medicines is on the shelf, and you're getting to what you need. And I'm barring quality from that side, because quality for now, we have issues about access. So access is an issue. And medicines and supplies on the shelf, it varies between different provinces. In KP, for example, I work very much deeply in KP. In KP, the last percentage that I saw was 40% on the shelf. So 60% were out of stock on the shelves. And similarly, you have Sindh, and then you have Punjab. We have a system of independent monitoring unit that goes around all the facilities, the primary healthcare facilities, and takes away data. And it varies 70 to 80% in Sindh and about 80 plus in Punjab. And it varies. It's very seasonal. It's every month. So that's medicines and supplies. We don't have a very efficient system of forecasting, quantification. It's a very archaic, ancient system where you just gather data. It's not very like if you have a facility in Shekhupura, what is its utilization trend? What kind of patients are you seeing? What kind of disease patterns are there? And then you come up like you need this, this, this. Then you quantify it. You forecast it. So these are the disease patterns, and we will see their seasonal trends as well. And then you put them into a quantifiable thing. It goes, and then that's how the stocks come in. But that doesn't happen. So we have issues in the whole medical and supplies chain, and in some provinces, you wouldn't even find a warehouse where the drugs are stored, resulting in that you would just store in some odd room where the medicines would be there expired, and even I've seen water flowing through the medicines, which are procured in billions of rupees. So that's medicals and supplies. Coming to the data systems, we have, the DHIS, which is the Disease Health Information Systems, which is like very, very old, 20, 30 years back. But I would say it's garbage in and garbage out. Please don't quote me on this, but that's data that somebody, a technician, would put, okay, we had three cases of malaria. Okay, next day it will be 4. It's just about his whims. We're trying to improve it. There are programs to improve the DHIS, and I hope it gets improved. But I will be talking about what Punjab has done, what other provinces have done to improve the data. So data is an issue, and I would always say what gets measured gets done. What doesn't get measured doesn't get done. So I think in the age of 21st century, with a country like Pakistan, which is a nuclear capacity capability, if you cannot improve your data systems around health, which is the bread and butter of all politicians. Health is political, by the way. Health education, especially health, is political. So don't, I've been hearing that health is not political. Don't make it political. I was just in Japan. Everybody is now trying to build it, the case for health for politicians, because politicians get reelected on 2 things: education, health, and all of that. So very, very basic things. So keeping that aside, there are dismal, indicators, but I'm an optimist. There is hope. And as we're hoping for the country, I hope for good health to prevail. There have been models that have, actually been very positive. But we should just see how much we are spending and how much we are getting and what kind we are getting. If we're just spending $12 by the government and then the rest of out of pocket due to various reasons, we should also see about the quality of care, the accessibility, the availability, all of those angles. I'll stop here and maybe we deep dive in one of the things that we want to. And one of the questions, sorry, for audience who are not privy to health sector, the health sector is organized into 4 key levels. We start from community levels. in which you've heard lady health workers. These are community health workers that go door to door in the villages and households. They have a certain, role or a job to do. They have devised job descriptions. Then you have a basic health unit. It started in 1947 as the Boer Committee. So I can go into details, and then you have a rural health center. So basic health unit is like manned by a doctor, which I preferably think. I've seen all the systems. I was in Indonesia seeing their health systems. I was in Kenya seeing their health system. Kenya, by the way, is like Pakistan. So it's not important to have a health to have a doctor who is high paid, high skilled to be manning those BHUs. There are different models around that. And then you have a rural health center, which is approximately 5 to 10 bedded, depends on various provinces, and which can have IPD, which is inpatient care. And then you have a Tehsil headquarter hospital. That's the first level of hospital in a Tehsil level that you do. And then you have a district headquarter hospital, which is at the district level, like a Sheikhupura district, a Kasur district. One hospital, you can have just Tehsil headquarters, which are different Tehsils. For example, if a district has 3 Tehsils, you could have 3 Tehsil headquarters. And then you come to the tertiary care hospitals like Mayo and, PIMS and all of those. These are tertiary care. We also have quaternary care, which we are not defining in the system, but I believe these are quaternary care like the PICs and the PKLIs of the world, which are specific, for example, cancer related or OBGYN related or anything related to that. So that's how our system of health is organized and structured so that you have an idea. The BHU RHCs are more rural. They are in suburban centers, but in urban areas, you generally have those district headquarter hospitals and tehsils, and then you have those tertiary care hospitals. The community health workers are mostly rural. They are not in urban settings. And one of the things that we should see is that, for example, I'll just take one indicator, CPR, which is contraceptive prevalence rate, is equally bad even in urban areas. So it's not an urban-rural issue, it's a health issue catering to both urban and rural areas. I'll just stop here.
Thank you, Shabana. Very informative. Mariam, you know what Shabana was talking about in terms of data and the need for data, whether it is to forecast, whether it is to plan and deliver good quality services is essential. And I know that you have been looking at a lot of sort of, health technologies and looking at the way to collect big data across the health sector. Can you give me a little sort of more information, on, do you think, firstly, that technology and digitization can be a way to overcome some of the challenges of service delivery in the health sector? And do you have any experience on the kinds of programming that has brought in this digital technology?
Thank you. You're asking a technologist if tech is the solution. My answer will always be yes. But I think that I started out more of an optimist when I started into the health space in Pakistan. Much of my work in the last several years has been looking at maternal health, and this work has been funded by the Gates Foundation, by Google, and the Patrick J. McGovern Foundation. And what we've been trying to do is figure out how to support, as Dr. Shabana has laid out so beautifully, just the very vast and very problematic landscape in which we are working. We have a very large population, and we could keep adding infrastructure and resources, but I don't think we'll ever catch up to our population. I don't think that's going to happen. And that's sort of an ideally suited problem for tech. And I think in the last 5 years, technology sort of caught up to a lot of the human capabilities. So the goal really is to think about technology not from a tech perspective, but from a very human-centered perspective. And so how do I build something that folks can actually use? If I create, for example, an EMR system, and EMRs are one of the main areas that we work in, and I'll explain why they are so important. especially for maternal health. But if I'm building an EMR system that requires you to have desktops and infrastructure and servers in your hospital or in your clinic, they might work for a month or 2 months. I would really need to upskill everybody working with that system. I would need to teach them. A lot of these folks are not entirely comfortable with English. If even if I make my system in Urdu script, for those of you who've ever seen it on a computer, is terrible. It's really horrible script. And so how do you create a system that everybody can use, that is inclusive and equitable? And then aap unko sikha bhi do, kar bhi do. What happens when a system breaks down? We don't have the skill set to repair these systems, right? So then, you're waiting for somebody to come and fix the system. You're waiting for, we've been in clinics, we've been in hospitals where there is no internet. The internet's just down for the day. And what we've seen is doctors, nurses, midwives just sitting. There's a line of patients all the way out the door. The system isn't working because there's no internet. And most of these women, because I work primarily in maternal health, most of these women are not coming back. So they had to have their husbands or their sons or some male family member take the day off and bring them in to the hospital or the clinic. And now nothing has happened because the internet was down. So how do you create sort of systems? That's the big challenge here. How do you sort of take this emerging tech and how do you contextualize it? How do you reimagine it to work in a context that is so complex, like Pakistan? I think I 100% agree with Dr. Shabana. I don't think that doctors or more qualified doctors in BHUs or rural clinics is the way forward. I think upskilling, sort of the model that I've seen that has worked really well in Africa, is midwives. I think for maternal health, midwives are amply qualified if you have a solid midwife program, but then also if you can create tech that supports these midwives. So when I started working in maternal health, one of the first things was to do a lot of field work to understand what are the challenges. And now most of you who work in healthcare will understand sort of the 3 Ds, right? Delay in reaching care, delay in getting care. And so we thought, how do you, if there's a woman who's, sort of peri-urban, rural, and how do you get her enough information to know when to go to the hospital? Can you get her to a hospital in time? If you can just plug that, we can maybe sort of have an impact on the number of maternal deaths. It's a very simple thing. If a woman asks me, can she send me a message on speech, a voice message, to say, my stomach hurts, I'm feeling dizzy, or whatever the symptoms? Can I, with some kind of predictability, get back to her and say, okay, you need to get to a hospital in the next 3 hours, and here's the nearest hospital to you. This is where you need. Don't go to a BHU, don't go to a clinic, because they'll just keep referring you. How do you do that? And the reason we really wanted to do this is because we kept hearing stories from the field of women who would go to the BHU or who would go to their dai, and the dai would say you're normal. The woman would go back and say, I'm feeling dizzy. The dai would say everything's fine. Then she'd go back and say, well, now I'm feeling a bit. I'm seeing blurry. I'm not able to see. Mujhe chakkar aa rahe hain. The dais and the midwives would keep saying everything is fine. You're all okay, until the woman would start seizing. And we've seen cases of women in December, middle of the night, put on the back of a truck, taken to the BHU, taken to all the layers of the system that Dr. Shabana has just highlighted, until they make their way to a hospital, at which point it's too late. Right? And what it was just preeclampsia, which is the third leading cause of maternal deaths in this country. And if you can catch it early, if you can diagnose it early, there's something you can do about it. And so we said, maybe we can build a predictive model that can just tell you, you should go to the doctor now. Because this is, I think, a national attitude of haldi doodh le lo, and go lie down and go take a walk and you'll be fine. Sometimes it's urgent and you're not fine, and you need to sort of bridge that gap in reaching care. And we went to the public hospitals. We went to Lady HSN and we went to Lady Willington, and we said, we need your data. Aapne data ki baat ki. And that's what we went for. We said, can we have your data to build these models? Because I need data of pregnancy symptoms and outcomes, women's pregnancy journeys, to be able to build any kind of equitable model that will do a good job in predicting anything. And they said, this is fantastic. We would love for you to do this, and we would love to give you our data. And we'll give you our data. So they took me to a room, which is floor to ceiling paper documents. And they said, here's our data. It would take me 10 lifetimes to digitize that data and to do anything with it. Now, your big fancy private hospitals like National have this data digitized, but that's not a good predictor of the vast majority of the women, because National may you have women who are of a certain class, because in Pakistan, not only is health political, it is classist, and it is gendered. And so, sure, I can get data from National, but that data is no good to me to do a generalized predictive model for low income women who are not getting supplements, who are not having those regular visits to the doctors, whose diet is very particular. And so that brought us to, that made us realize, even before you do any kind of fancy diet, and this was 7 years ago, so before generative AI. And so we, at that point we stopped, because before I could do any kind of modeling of anything, I needed good data, and there are no systems in place that sort of collect that data. And then we had generative AI. And more than generative AI, what we've had in the last couple of years actually is a shift to very powerful language models, ASR systems. And so what that has allowed us to do is, on your simple phone, you don't need a computer. On your phone, through speech, you can record medical histories. And what we can now do is convert them to a formal standard EMR. So आप कहीं भी बैठे हो, अगर आपके पास स्मार्टफोन है, आप कह सकते हो, I have this woman, she's come in, and you can do it in Urdu. You don't need English, you don't need text. So in Urdu, you can say, I've had this woman, she's come in, वो पहले उसकी इतनी pregnancies थी, इतनी miscarriages थी, इतनी natural births हैं, इतने C-sections हैं. All of that data, आप उर्दू में record करो, our system converts it from Urdu speech to text, translates it, fills out an EMR, comes back and says, आपने मुझे last period date नहीं बताई, आपने ये नहीं बताया कि जो पहले बच्चे थे वो उनकी ages क्या हैं. All of that, and we're working with doctors at Shalimar to create this system. It was trialed at Shalimar. And we frankly, we thought we'd done a great job. I was very pleased with myself. The Gates Foundation thought we'd done a great job. And we thought, this is great. Now let's take it to the public health sector and see how it performs there. Lady Wellington mein interest tha. We went to them. And they said, ye to nahi chalega. And we said, but Shalimar mein chala. And they said, no, because the thing is, why don't you spend a day in our OPD, and then you come to me and you tell me why this will not work. So we spent a day in the OPD. Wednesdays and Saturdays unki OPD hoti hai. We spent a day there. अब वहाँ पर एक कमरा है, 4 डॉक्टर्स बैठे हुए हैं, हर डॉक्टर के आगे 7 औरतें बैठी हैं, बाहर लंबी लाइन है, ग्राउंड में औरतें लेटी हुई हैं, pregnant women. And we went back to the obstetrics head and we said, yeah, it's not going to work because the doctors just don't have the bandwidth. Right? Medical data इसलिए record नहीं हो रहा because आपके doctors के पास time नहीं है. वो 2 मिनट दे रहे हैं हर patient को. वो अगर examination कर लें बहुत बड़ी बात है. So what do we do now? And so we sat down and we looked at the way things work and we said, and there are examples of this, right? And I'll come to an example, a really great example of the ways in which tech has sort of started to plug in the gaps for South Africa. And we said, okay, there's a very simple solution to this. Most of the women in the OPD outside जो wait कर रही हैं, उनके पास एक smartphone है. अब उनका अपना है, कईयों का husband का borrowed है, कईयों का बच्चों का borrowed है, but phone है और उस पर उनके पास data है. और वो WhatsApp use कर रही हैं. So now what we're doing is we're collaborating with Turn.io and we're building a system that will allow them, the women themselves, to record their own medical data. We're prompting them. Okay, and we're using prompts that the doctors are using. Right? कि बीबी पिछले महीने में बुखार हुआ नहीं हुआ. That's what our system is asking them. And these women are coming back and saying, हाँ मुझे बुखार था नहीं था अपनी language में. WhatsApp के ऊपर हमें voice notes भेज रही हैं. WhatsApp उनको use करना आता है. There's no overhead. उनको कुछ download नहीं करना पड़ेगा. And that turns into an EMR. Right? So by the time they make it into the doctor's room, the doctor has that EMR and they just need to add examination details. Right? ये बिल्कुल पॉसिबल है कि हम तीसरे पब्लिक हॉस्पिटल में जाएं और वहाँ पर सिचुएशन बिल्कुल डिफरेंट हो एंड दे से कि ये हमारे नहीं चल सकता. we'll find out. But I think there is great potential in speech-based AI tech to help not just, so what our system does is EMR generate करता है, but and that was the original plan, कि बस EMR हमने generate करना है. Once we started working in the field, what we realized is कि diagnostic support की बहुत ज़रूरत है. Right? Our system, generative AI systems can look at a vast amount of data and come back to you and say, there is a very high likelihood this woman might have hypertension. Can you please check this, this, and this? Right? There's a very high chance based on her history and based on all the other records that I'm looking that she might have gestational diabetes. Here are the tests you need to run. And so you're also providing diagnostic support, and you can do that with doctors. But where we are finding is really impactful is with low skilled maternal health workers, right? Because we know that a lot of the healthcare in Pakistan is informal, especially when it comes to maternal health. It's not in the formal sector, right? So so this is the sort of system that they can use to help create the data, but then also to help with diagnostics. The one example I will give you actually, and we're working with the team that put this out, is Mom Connect. How many of you have heard of Mom Connect? Okay, so Mom Connect was a system that was developed in South Africa, and it started out as an SMS-based system to plug this gap of, एक औरत आई, उसने एक अपना विजिट किया किसी भी दाई या आपके पब्लिक हेल्थ, उसके बाद वो नहीं आई, एंड देन 9 महीने बाद वो इमरजेंसी में आ रही है बहुत बुरी हालत में. हाउ डू यू प्लग दैट गैप इन द मिडल? हाउ डू यू अप्रोच दीज वुमेन, एंड हाउ डू यू help them when they're not showing up to healthcare facilities? So they created an SMS-based system where women, when they first came in, they were registered on the system. उनका phone number ले लिया जाता था और उनको SMSs जाती थी. This month you should expect this and this to happen. If you're experiencing these symptoms this month, here's what you need to do and here's where you need to go. And they found that to be very impactful. Now the problem with an SMS-based system is if you can't read or write, what do you do? So then they put up an IVR system. It's an interactive voice. जो आप बैंक को जब कॉल करते हो और आगे रिकॉर्डिंग चलती है कि इंग्लिश के लिए एक दबाएं, उर्दू के लिए दो. That's an IVR system, right? So they created an IVR system कि औरत के फोन पर कॉल आ जाती है कि with all the information. And that's great. It's not scalable and it's not sustainable. That's the problem with both these systems, right? And that's what's fundamentally changed in the last 5-6 years. If it's an IVR system, somebody has to pay for the airtime. जब आप बैंक कॉल करते हैं, you are paying for that airtime. So अगर आपको वो 1 घंटा होल्ड पर रखेंगे, आपको उसकी कॉस्ट पड़ती है, right? These women are not going to put up with that cost. SMS आप भेजते हो, उसकी भी कॉस्ट है, right? Which means you can't scale this. But then around 2017, 2018, something phenomenal happened, which was WhatsApp. Everybody got a data package, and everybody was using WhatsApp. So now Mom Connect has registered approximately, and the government now owns it. The government has taken ownership of Mom Connect. It's deployed in all of their public health facilities. Any woman that walks in gets registered, and then she starts getting these WhatsApp messages. It's catered to about 15 million women in South Africa currently. And they've done a lot of RCTs to sort of study the impact of this. And it has been phenomenal in terms of the gain in knowledge, but also the behavior change of pregnant women as a result of that gain in knowledge. So I think, Sehat Kahani in Pakistan is doing something really phenomenal as well. Those of you who are aware, what they're doing is plugging this gap in resources by doing telemedicine. Right, so aap kahin bhi ho, you can just call in and within a couple of seconds be connected to a doctor, and they have sort of a great infrastructure across, because all you really need is a woman who's a doctor, even if she's sitting at home, to give a couple of hours a day. I'm going to stop here.
Just to add, Maryam, I think when you compare the South African model, just look at their literacy indicators and look at their connectivity, because I've been there. It's a contrast to Pakistan. As a practitioner, yes, I feel tech is an enabler, but for now we have not reached that stage that everything is driven by AI. To be honest, countries are experimenting. I'm a Canadian as well. AI doesn't work there as well. We're still trying to experiment that as well. So to say that, everything, the EMR, I have my difference of opinions on that, because we in Punjab, when I was member of the planning board and I was heading health, nutrition and population, we tried to have a unit which is called HISDU, Health Information Delivery Unit, which starts in our own resources, very homegrown, nothing from any US, UK systems, everything homegrown. Our people are smart. We need to realize this. Pakistani people are smart people. They do exceptionally well when they go outside. Exceptionally, they are very, very competent. I must say that. It's just that I think due to the systemic effect here, they become lazy and do everything under the sun and game up. But for that HISDU, we have an EMR. I know it is not the ideal one, but every BHU and RHC generates report. It's still in the process. It's been a 7 years journey very cumbersome, paise kahan se aayenge, kahan se nahi aayenge. So every person who gets into a BHU or an RHC, you have all the data that comes to the head office in Punjab. We know the prescription. So AI would tell you ke will model. AI is a modeling technique. It will tell you the chances of her having hypertension. Check for hypertension. She has to be checked. So it has to be service delivery. It has to be diagnostics. So that entity has to be somewhere, right? वो तो already है. So Punjab is not that bad. 86% of your, 86% is your skilled birth attendance. It's not that everybody goes to a DI. 86 is comparable to other countries like Kenya, etc., which are low middle income countries like ours. DIs and traditional birth attendants have been waived off. The ANC rates are okay. We have a high maternal mortality rate. By the time I talk to women, or 3 women would already have been died anywhere in Pakistan, which doesn't come on the TV because it's a regular thing. And we see the statistics, and some infants, which are double the number, might have died while we finish our talk. So I think tech is an enabler. We have to use it. But in country like ours, where I'm trying to find Sehat Sahulat ka data, which is all mobiles. I work on Sehat Sahulat insurance. 70% of the data is not validated because जो mobile number उन्होंने दिए थे वो validate ही नहीं हो रहे. So our mobile penetration in the country, we must have very good numbers, but I think it's still, there's a gender perspective into it, and you know much better than me. I'm still trying to figure out, because we're doing a research study on cesarean sections and NVDs for Sehat Sahulat people, but we're not able to validate that data. So I completely agree with Maryam. We have to find interfaces where we do not business as usual, but for us to reach that level where we do this would take a lot of time. We're talking about basics here. अगर आपका एक basic fertility pill नहीं है, अगर आपकी basic antibiotic नहीं है, we have to make their policy. I'm a policy practitioner. We have to make policy choices. आप ये सड़क बनाएंगे, या आप अस्पताल बनाएंगे, या आप अस्पताल को ठीक कराएंगे. 3 choices है ना. आप अस्पताल बना के थक गए. If you cannot, even in Mayo for now, there will be so many empty positions, especially your basic sciences. These are policy choices that politicians make. We as advisors can help them to take a decision based on data, but health across the board that I've seen in all countries that I've visited and seen the health systems, it's evidence, but it is also political. Because I'm a politician, I need to get reelected in 5 years. Not that I'm making a case. I think we as practitioners and we as academia has failed and not done our job of speaking in the language of politicians. That's what the discussion, I'm just coming from the HSR in Tokyo, in Nagasaki. That's what we realize around the globe. We as practitioners and academia have failed to put policy perspectives in the language that a politician understands. Their politicians are educated somehow. We have educated politicians, but the kind of decisions, I'm not going into some debate, but you have to revisit that. So just on that, data is important, data quality is important. We can be doing these pilots. Sehat Kahani is absolutely fine. What is the reach? What are the numbers? And as a medical doctor, we have ethics. Are they doing telegynecology? No. There are ethics when you have to touch the abdomen. You have to see this. You cannot ask the woman, kitne ho gaye, because you're not touching her, right? There are ethical issues around but it is a game changer for areas that are inaccessible, unreachable, where doctors are not there. So there has to be certain parts of where to use telemedicine, how to use telemedicine. I'm working on a paper with my colleagues because I also advise Africa's. We're working on a telemedicine paper, which is strategic purchasing of telemedicine. How do you purchase? In health financing, it's a term. So you have domestic resource mobilization, strategic purchasing, and pooling. आप किस तरह उसको कर सकते हैं? How do you take those telemedicine services? It is not that जी आपने 4 डॉक्टर बिठाए, आप उनको सर्विस दे रहे हैं. There is a way. There's a method to the madness. How is it inducted in health insurance programs? That's a different ball game altogether. But completely, we are in the 21st century. Data is important. Data quality is important. New ways of getting data is important. But I think personally, and you people can differ with me, we are not at that stage to do very high level and very sophisticated AI technology. We are trying to build an AI into the HIS2. Let's see how it goes, just to see if prescriptions में chlorhexidine kitne likhi thi. That is easy. But saying, I wish and I pray this works and we are able to scale up. But I think we have some time for this to take up. And if people would tell you that it's a little bit complex and unpracticable in the government setup right now, I would agree with them at this point in time. Maybe after a year, maybe after 2-3 years or 4-5 years, maybe if we are so tech savvy, हमें तो आप खुद कह रही हैं, we don't even have internet, right? And it is the mother, it is tech is an enabler. Who is using technology is the real thing, right? If a mother is getting a call, वो तो अभी भी उसको लेडी हेल्थ वर्कर कह रही है, भाई बीबी तुम्हारा तीसरा सिजेरियन सेक्शन है, इस डेट पे आना. शी इज नॉट गोइंग, राइट? सो आप टेक के थ्रू उसको करें या ह्यूमन से करें, देयर इज अ प्रॉब्लम. I'll just stop and maybe you have additional points around it.
So I want us to move out a bit because we've talked a lot about maternal health and we've talked a lot about tech, right? And when you are looking at health system strengthening and you are looking at a public health system for a country like Pakistan, yesterday we talked a lot about political economy in ways where we realize that, you have spatial exclusion, you have, you have provinces, you have districts, you have 250 million people in this country who have very unequal access to healthcare. If you're sitting in Balochistan, tech doesn't count, right, for anything. Your access to even a BHU is iffy, and as I feel as if you are, if you are looking at political economy, if you are looking at what are the kinds of policy decisions, what are the kinds of financing decisions you need to make sure that every citizen in your country is being catered to, you have to have a broad-based approach. You have to look at it from a perspective of how do you deliver in areas which are very low accessibility, as well as in urban areas. Even yesterday, where we were talking about, where we were looking at what is the urban rural divide, right? And there was some, idea that maybe it's not 60-40. 60, everyone says it's 60-40, 60 being rural, 40 being urban, that it's actually the opposite and maybe more in urban or peri-urban areas. And yet, you have such high health, sort of negative statistics around health, it means that even your private healthcare systems are not being able to provide for very reachable, very accessible citizens for the demand, right? So as a government, when you're looking at how do you strengthen health systems, how do you actually bring about certain improvements, and what what the basic health burden is, other than looking at maternal and infant mortality, you've got I think diabetes, you've got heart, yes, hypertension, you've got critical, some are non-communicable critical diseases, then you've got the communicable critical diseases. What kind of systems do we currently have in place that could be expanded or improved to manage the wider burden of disease? And I know we've talked a little bit about the Lady Health Workers Program, and that is also very fixed on mother and child, right? But what about even for men? What do we need to do to maybe expand certain kinds of very basic primary or preventive services that could ease the disease burden later on?
Samia, first of all, we have a mixed health system. We already know there's a private. In the morning, I'm a public professor, and then at night, I'm a private doctor. So we have a mixed health system, and there is no checks and balances or regulatory compliances to what I do in the morning. I ask my patient, come in the evening, and he has to pay out of pocket. So that's one. We need to realize what kind of a system are we running in. I personally believe that the government should be a financier and a regulator of health and not into service delivery, because two largest departments in any governments, in any provincial governments, are health and education. And you know the plight of both. I don't want to go into educational indicators. So one is, I think the government has realized, when I first started here in Pakistan as a public health practitioner, there was no question that we could talk about the private sector. And the private sector was absolutely absent from the policy tables of the donors, development partners. It was just government and the donors and development partners. I think seeing that trajectory, I think the government realizes that it is not their capacity or capability to deliver everything, and that's why they realize it. There are three things that lead into partnerships. One is the philosophy that has changed, that public sirf garibon ke liye hai and private is for upstart. That was the ethos that you started in the healthcare, but that has changed. You have more private practice people looking into rural areas, and you have more wealthy people presenting in public tertiary care hospitals. So I think that has changed. That's the philosophy. The second is interdependence. Can you name any government in the world that is not dependent in health on the government? Of course, yes. Even if it's not delivering, even if the government is not delivering, the policies, the taxation, the regulations from the government all apply on health for the private sector. So there is a kind of interdependence. The third is benefits. What is in it for me as government, and what is in it for you as private sector? So that is very important. And I think the government realizes it. I was just recently nominated as the chairperson. I think I'm the only female chairperson board of governors in Khyber Pakhtunkhwa. I wish we have more women. So I lead public-private partnerships for KP. So public-private partnerships, they've realized, all the provinces realize that they cannot deliver on health alone by themselves. That's a given. And that's a very positive thing that they've realized. In Punjab, when I was here, member of the planning board, we said, ये जो आपका switch नहीं होता, ₹5 का switch, ये खराब था, and the MRI and the CT scan were down because the switch was खराब. और switch को change करने के लिए you have to write to the DHO would mobilize, फिर पैसे आते थे, और switch ठीक होता था. I'm just giving a basic example. What is the opportunity cost of not using the CT scan or MRI, which is for the people? What amount of money have you spent on it? I think nobody does that analysis. So what we did is, ye lein ji, either you run as a private sector, pay per service, 10 MRI karenge, ye cost milega, usse above karenge. So we try to develop those models, and I think they're working here. There was another model that we said is, you get your machine, the government does not spend as private sector, we will give you the money and you can build that cost in your MRIs and your CT scans. So there are different models that you can do, and we try to do in Khyber Pakhtunkhwa. So in Sindh, you have a very important, I wouldn't say it's a true PPP, but PPHI is the semi-government sort of an agency set up by the government. Flexibility, they get a one-liner, मतलब 16 अरब उनको मिल जाते हैं, no questions asked, and they run the primary healthcare system of Sindh. It's a private entity, nothing to do with government's charter of accounts, public financial management systems. They don't go through that rigmarole. They just get a one-liner. जी ये आपके पैसे और ये आप facilities चलाएं. जो हमें problem that I'm working with the government of Sindh is, there should be questions asked. There should be indicators done कि हम पैसे तुम्हें तब देंगे जब तुम ये utilization होगी, ये होगा, nutrition के ये indicators देखोगे, which is it's very bureaucratic, it's very political because it's a very big organization running since 25 years. So we're trying to build in those indicators. KP mein public-private, I think a public-private partnership is the new method of financing. It's a new era, but we need to nurture the private sector. In KP, so aapko pata hai, KP is divided into two parts. Now it's one part. One was the merged areas, which is rest of the districts, and the FATA and FANA, which were merged together with KP. NMDs kehte hain, newly merged districts kehte hain unko, and they're like 10 to 12 districts. Worst indicators, you could go to a maternal mortality rate of 500, 800, like Balochistan and Khuzdar and all. So bad indicators, less financing, more tribal systems. So what the government did was, उन्होंने कहा ऐसे हमसे तो अस्पताल नहीं चल रहे, तो आप ये 16 अस्पताल थे, different areas, different districts, तो उनने private sector को दे दिए. So they made up an institution, KP Health Foundation. So they mandated under law कि आप ये सारे public-private partnerships enter कर सकते हैं. It could be anything. It could be a BOT, which is build, operate, transfer. It could be a BOLT, which is build, operate, lease, transfer. Or it could do very basic PPPs like contract management or management outsourcing. So जिस अस्पताल को हम गए और देखे, there was no doctor in a DHQ, मतलब category D उसको कहते हैं, no doctor, no gynecologist, and all those. और आपको पता है वहाँ खवातीन का है, there is a social system also. We gave it to the private sector on the same terms. अगर government का budget 300 million है, आप 300 million में चलाएंगे. 30 crore दे दिए. 30 crore में हमने कहा कि आप चलाएं. They got a doctor, they got the positions, they started running, OPDs happened, IPDs happened. It was a success factor. Where did it fail later on? I'll tell you the whole story. It failed because private sector को पैसे time पे नहीं आ रहे. So I'm private sector, I invest money, I run your hospital, 6 महीने 4 महीने के बाद, under contractual terms, you have to give me 10 million. Example. Till date, since I joined, I have 10 people outside every day. Please हमसे अस्पताल ले लो. We can't run it because मेरे ऊपर तो 200 crore. I am liable as private sector to give it back, and the government is not giving me money because of various reasons. I won't go into detail. So just to let you know, one of the important recipes, success factors of any PPPs is one, clear roles and responsibilities, contractual terms, fund flows. For me, the fund flow is a barrier to any of the PPPs that you do. If you do not give money on time and you do not stand up to your promises, as government, you fail and you lose that private sector partner. So for me, going in the new vision of 21st century, PPPs, innovative financing. So I am just a student of health financing right now. I'm a health systems person, not a health financing person, but as a country director, I had health financing for this US-based company. I recently read this new financing tool, which is called Debt to Health Swap, D2H. So debt to health swap वो होता है कि जो countries जिनके ऊपर बहुत ज़्यादा debt होता है, country like ours, they get into agreements with the creditor countries. It is a bilateral agreement. For example, हमें फ्रांस ने जी example दे रही हूँ, $200 million का loan दिया है agriculture पे, किसी भी चीज़ पे. In a debt to swap agreement, what happens is you talk to the creditor country. The creditor country या तो लोन कम कर लेता है या उसकी इंटरेस्ट कम कर लेता है या माफ कर लेता है. वो कहता है I would forgive $50 million in this loan if you invest it into your social sector or health sector. So that means you improve and increase the monies that you get for health. Because the way Pakistan is doing, abhi bhi GDP is not 8% or 5%. It is still not very good as I see. It's 3 to 4% the last that I see. I might be wrong. So the GDP is also linked because it gets the money. So अगर आपका pot में 100 million है, उसमें से आपने सड़क भी चलानी है, आपने ये भी चलाना है, वो भी चलाना है, तो health को आप कितना देंगे? So I think one of the things that you need to do as a country is also try innovative financing mechanisms. Try to get more money. I'll give you an example. India said all the MNCs that have a turnover of about $100 million or whatever figure that looks like, we will cut 1% of your tax and invest it into a nutrition fund. That nutrition fund, it's compulsory at a certain threshold. आप ये पैसे जमा करेंगे और ये जो होगा, ये पैसा जाएगा आपका nutrition investment में. And then they started. So my point is, PPPs is very good. You can leverage on this. But mind you, with the right kind of regulatory mechanisms, right kind of contracts, right kind of vibes that you give as government, right kind of budgetary flows and mechanisms, and transparencies and accountabilities, then you leverage on innovative finance. How can you get more monies for health? आपके politicians उतना ही देंगे जितना वो दे रहे हैं. I've been tracking for the past 5 years. We have increased पहले 10% था, फिर 11 हो गया, 12 हो गया, 1-1%, 2-2% इंक्रीज हो रहा है. But if you want massive gains in health, you have to think outside the box and try to leverage CCTs if you want. It's not a health financing mechanism. It's the way that you use your funds, the conditional cash transfers. So you've seen the Mexico model, Progressa. So it's a good model that everybody talks about. I think World Bank ek project mein Punjab mein, there is a mechanism of CCTs. I don't know how well that's doing because we generally don't do research in RCTs in that area. I'll stop here and probably we'll take more questions around.
There's a Nashanama model, which is currently the CCT, which is going for
Yes, in the BISP.
nutrition.
Yeah, in the
in
BISP.
BISP.
But if you see the 2019 BISP report,
No, that's
it
not
hasn't
working.
changed.
No.
It hasn't worked.
But that's because of the supplement. Like, there's
Yeah.
nutrition has a lot more that needs to be doing. Mariam, I want to go back to you, and you know what Shabana has just said about public-private partnerships, about the way government should maybe be developing the policy, doing some of the partial financing, and maybe monitoring and getting that big data that can help achieve outcomes while leaving the implementation to private sector partners or whatever, you know, these public-private companies that are being set up. It's very interesting, but I think it would only work if your monitoring system, your reporting system, and your data collection was really strong. What do you see in terms of government's capability, capacity, intention of being able to then become that sort of monitor and data enabler or collector that can actually sort of see, you know, what kinds of results are coming through? Do you have any experience on that?
None of it is good. I know Shabana tends to be a bit more optimistic about what the government is doing. That has not been my experience, and I can only speak as a researcher who's just hung around BHUs and public health facilities. You know, I've watched the Histo EMR system in action in BHUs, and typically none of the fields are filled out except the medicine field because that's what they want to really track, right? They want to know where the medicines are doing, prescriptions kya aa rahi hain, but jahan par socio-economic या actual health के indicators हैं वो नहीं fill हो रहे हैं, and I can understand why. अगर आपके पास 3 मिनट पर पेशेंट है आप सब कुछ नहीं करोगे, स्पेशली अगर बहुत लंबा आपका डेटा बहुत लंबा है. We also saw lady health workers की को again with the data, right, trying to monitor and gather good data. They gave lady health workers, this was a couple of years ago, tablets कि आपने tablets पर सारा data collect करना है, and we saw the forms, वो English में थे, and there were a lot of forms. And when we spoke to lady health workers, वो कर ये रही थी कि at least the ones we spoke to, उनमें से एक कोई ज़्यादा यंग थी और थोड़ी ज़्यादा पढ़ी लिखी थी, वो रजिस्टर्स में डेटा इकट्ठा कर रही थी, एंड एंड ऑफ द डे उसकी जॉब होती थी कि ऑनलाइन हर एक के टैबलेट्स को लेकर उस पर फिल करना. दिस इज हाउ द गवर्नमेंट वर्क्स. I have zero faith in the government from what I've seen, right? Like I actually will go a step further from what Dr. Shabana is saying. I think that the health, from what I've seen, health in Pakistan, anywhere globally, health tech particularly is $1 billion business. I think Sehat Kani has shown us this. I think this space is ripe for private companies to come in and do this really well. And then the government can certainly come in and say, give us your data or help us monitor or whatever. मुझे नहीं लगता कि ये गवर्नमेंट की स्किल सेट में फॉल करता है. आई थिंक दिस इज अ रियली कॉम्प्लिकेटेड टास्क. लेट मी आल्सो गिव यू वन एग्जांपल.
No, before you do, I'm going to challenge you on this now, right? So I feel there is an ethical component over here that we are lacking, right? You give it to the private sector. The private sector will go, yes, in the urban areas, but they're not going to go out where it's going to be too costly or too expensive. So you're going to have huge inequality in accessing health. So
I agree with that. I agree with that. I think that there are a couple of things. I think that, again, I really see health much like anything else. At least this has been my experience as somebody trying to do health tech work in this country. Everybody goes where the money is. And so if you can make it profitable for folks to sort of also go urban, they will. Really, there is a great example of companies in India who have done this, and they've done this with rural sort of, just because that data was gold, right? And there's somebody willing to pay for that anonymized data, so they're happy to go rural to get that data, right? So I think sort of a lot of what we're talking about now, data can be monetized, right? Data is, and I absolutely agree. I think where the government really needs to step in with the tech is where are the policies and where are the frameworks? How do you do this ethically, right? As a health tech company, I can go in and get all this data. I am getting this data from low-income patients, right? LUMS binds me to particular IRBs, as does Lady Wellington and Shalimar. And so there's not much I can do with the data. But if I was a private company, I could sell that data. This is very, very valuable data. There is no current policy that prohibits me from doing this, right? Where I store that data, I've worked with organization. I was in Dakar a couple of months ago. And even in Africa, there are strict guidelines and policies around where you can store that data. उनका सबसे बड़ा मसला ये है कि we cannot store this health data in servers that are outside of this country. We don't have any policy or framework like this. I could store it anywhere in the world that I wanted, and then I could anonymize it and sell it to whoever I wanted, right? I could allow my systems to be used by the Nestles of the world to market to really poor low-income mothers, and that has happened globally. There are no policies that prevent me from doing this. So I think that's the sort of the government really needs to wake up and take a really strong, like, saying कि oh, हमारा मुल्क अभी 10 साल तक AI systems adopt nahi honge. That's not true. It's coming. It's profitable. There is money in it. There is investment coming into it. I can't tell you how easy it is for me to have gotten money to do this work. As an academic who's always writing grants, it is a pain. This particular project, people can't stop giving me money. And it's a bit of a shock to me because this is coming. There's no stopping this. There's no saying कि oh Pakistan बहुत दूर है अभी. But the government has not woken up to really taking a stance on sort of frameworks and policies around health data. आपका government तो ये करता है. आपने COVID की शुरू में बात की. One of the things that I don't know how many of you know, the government put out a COVID WhatsApp hotline. And I was very pleased that they had woken up to the potential of WhatsApp, right? It is the most ubiquitously used. एक औरत बिल्कुल पढ़ लिख नहीं सकेगी. WhatsApp वो use कर रही होगी because it allows speech communication, right? खैर, I was very excited. I think I was one of the first people who signed up to this number. सब text है. सब text है. आपने WhatsApp पर किया, government की hotline है, आपने public के लिए किया, और सब textual है. उसमें कोई स्पीच नोट्स नहीं थे, उसमें कोई वीडियो आपकी डेटा नहीं था. देयर वर नो वीडियोस दैट वर शेयर्ड. यू आर डीलिंग विद अ पॉपुलेशन, एज यू सेड, दैट्स रियली लो लिटरेट, एंड इट वाज ऑल टेक्सचुअल. दिस इज वेयर योर गवर्नमेंट इज. So I don't see, I think it's really the sort of the private sector that's waking up to the billion-dollar market that is the health tech market in this country. Sehat Kahani has set up a fantastic example of how to make this really profitable. The amount of money they've raised, I don't think any other company has raised that money in this country. And so I think where the government role comes in is really being able to protect its citizens and creating policies for the data, for the ways. अब मेरा सबसे बड़ा प्रॉब्लम ये है कि ठीक है, हम एक बहुत उसको फिश बोल में अभी पायलट कर रहे हैं, but diagnostics can go wrong. That's why we're working with doctors and we're not working with midwives right now. Because what if, like, we want to be 100% sure there is not even it's like a 0.5% margin of error for hallucinations, right? You want to be very sure that any system that's providing diagnostic support will not, like, we ran a system for young girls to help them with their menstrual health, right? Intimate health. Now the system, and this was a very closed experiment, and we had doctors on board who were monitoring the answers. The system is telling a young girl who's saying, I am cramping. What do? The system is saying, जाओ जाकर धूप में पेड़ के नीचे बैठो. And so who's monitoring this? There is nothing stopping me, by the way, from deploying the system. There is no government policy. There is no regulation. दवाइयों की तो फिर regulation है, आपकी medical devices की regulation है. Right? You can't just put a medicine out in the market. Where is the regulation for AI tools? They're coming. There is no question that they're coming because there's money in it. And where there is money, the private sector will set it. Right? They'll step in, they'll get the investment, they'll build these tools, and in this country, they will deploy these tools. Where is the framework?
So on that note, I want to open it out to the audience. And if anyone has questions on what you've just heard in terms of whether it's digitization, whether it's health financing, whether who should take responsibility and ownership at the end of the day, public health, the ethics behind it, the ethics behind data collection and usage, and also the ethics behind public-private partnerships are still all, it seems, in Pakistan, yet to be defined or yet to be properly frameworked with the right kinds of policies put in place. And then we need to have government that is visionary enough to actually think through some of these things and start working towards this end. So leaving it at that, any questions, please? The gentleman first and then the lady second. And then
My name is Muin Afzal. I was until 22 years ago in government service. Since then, I've been working with various corporate entities. Um, our subject was health and governance. And nearly 30 years ago, I was health secretary in the government. And that was the time when the Lady Health Workers Program, incidentally, was just starting off. And of course, the advisor or minister I worked with was Shahnaz Wazir Ali. And of course, the program got off to a good start. And I think during the first decade of the present century, it worked well. I also remember the polio drives. In those days, we were down to below 10 a year. And in fact, soon after I left and moved on to finance, it came down to 2, 3, 4 a year. You were discussing, the health insurance schemes in Imran's government and the way COVID was handled. I think generally we all felt it was done pretty well. Now, health and governance, we've been looking at public-private partnerships, been looking at IT, the use of IT and prospects. I think one thing we haven't looked at, and I was wondering what your views are, is the effect of the 18th Amendment on what's happened in Pakistan to the health sector. And then again, seeing recent developments in our politics, where amendments can be passed within half an hour or 1 hour, they're normally very tedious and impossible. I thought one of the things maybe that needs to be done is to put at least public health part of health back into, the federal government's responsibility. If for no other reason, because you cannot handle programs like immunization, COVID, polio, without the overarching umbrella of the federal government. So I just thought I'd ask you what your views were on it. Thank you.
Yeah, sure.
Hello, I'm Dr. Numana Amjad, Professor of Psychology, and I work closely with the government sector, Punjab University, and then with Fatma Memorial Medical System for the last few years. My question is very basic to start with. Whatever, and Maryam, please, the digital systems access and things we were talking about, I've noticed the mental health symptoms could be a simple question but has not been included, and again in our counseling and consultation practice, I've noticed lack of awareness about health. So it's not about reach and medicines and systems. What are we doing? And that is a question to both of you, basically, about educating people about health. There's a huge stake of education in that. As an educated mother, I knew not to panic and run with my child to a healthcare provider, because I know this is a symptom of this and how I can help the child with high fever or digestive problem. And that education comes through generations of educated mothers, right? So one thing I see the poor people lack, it's not only medicine, hospital, or living in rural, they also the knowledge about health. So how can our system can be inclusive of providing, because we are still so far back in literacy, and so let alone health education. But there is a wisdom alternate system where grandmothers knew how to take care of the health, and mothers. So that if that is accommodated, we will reduce the rush at the hospitals where people don't know whether it's a medical thing or it can be help with really good home care. And so that's basically what I would like a response.
Assalamu alaikum. My name is Dr. Rizwan, and I am a probationer from the Civil Services Academy, Lahore. There was a mention of data, problems with data, in how there is a burden on the hospitals where doctors are really not able to reach to the patients because of the time they actually cannot give. Also, there was a mention of the public-private partnership in particularly in the context of NMDs. Since I come from Bajawar, so that's my area. I have seen it firsthand. And it was also mentioned that how the financial limitations are actually being a barrier in that regard. I have a particular question for Dr. Shabana, since she is the public health policy advisor for the government of KP. And the question particularly relates to the Sehat card intervention. There was a mention in the talk that political capital of this thing is huge, and politicians tend to like force more and more on this aspect of it. Inherently and indigenously, what I have observed personally in the hospitals, I think the cost that we are paying for it is rather too much. Since we are not able to pay for the expenses of so many other facilities, in the maneuvering in the exploitation of this Sehat card facilities, particularly in the private sector, and I will not just mention the private sector, also in the public sector, there are mafias. I would take the liberty to use this word. There are mafias, particularly, and they design. There are capes in this Sehat card, like 40,000 if it's a cape. The hospitals tend to arrange that money in the account of every patient in a way that they would count things which the patients never use. And there was a mention that data is not valid. Even, madam, if you are able to reach to those people, whether they have availed those facilities, they're not actually aware of what they have availed. Starting from the injections, starting from the procedures, starting from the surgeries. Even there are claims, ma'am, and since you being the policy advisor, you can actually navigate through those things. You can actually probe those things. There are even claims that patients have undergone surgeries where there actually were no surgeries, but there were just skin stitches applied. So I think that since you were mentioning that we are not being able as practitioners to build a case to the politicians. So if you are being able to build a case to the politicians in a way that Sehat card is, I would say, proving detrimental to the economic. We are paying too much of a cost for just a political gain. So I would want to hear your comment on this, ma'am, and if any remedies that you would kindly propose.
Thank you so much. Let me first correct you. I'm not a political advisor to any of the governments. Thank you. I'm not even a technical advisor. I sit on the board of governors, and that because the CM asked me as a technical person. I don't go into politics, especially Pakistani politics. Just a disclaimer. On the devolution part of it, sir, thank you so much and very kind to have you here. Sir, devolution happened in a hurry, but now, after so many years, I think we have the right capacity. Increased, I would not say right. There's never a right thing here. I think there are increased capacities in the provinces now. If you get back these programs to the back to the national government, I don't think it's a good idea. I also know the federal government. The federal government cannot even comment. मतलब उनकी capacity provincial government से बहुत कम है. So we would not let these programs. और सर हम devolution की बात कर रहे हैं. So devolution तो मेरे लिए provinces से ज़्यादा districts level पे, which hasn't happened even to tehsils and union councils for a country like ours. Indonesia is bigger than us in population size. The kind of devolution they have, and they're Muslims like us, the kind of transparency that they have. Her facility ka budget, I was shocked, I was amazed, and I was pleased as an Islamic country. They have all the budgets. अगर आपने 100 रुपए खर्च किए ना, आपके पूरे साल का बजट बाहर डिस्प्ले होगा. And the community asks them. ठीक है? एक तो literacy भी वहाँ ज़्यादा है. So on devolution, I wouldn't go back to the federal government. Yes, areas of importance, medical education, drug regulation, international health regulation implementation, emergencies is the mandate of the federal government. But I wouldn't go back on giving this back to a capacity which is not capacitated. So the provinces, I'm really happy and glad that the provinces are at a level that they are better than before. आप पहले वाले programs को देखते, so immunization और polio इस वजह से नहीं है कि वो provinces को चला गया है. Immunization के different issues है. Why polio is back? When I was working in the government, we were polio free for 4 years. You can trace that. There were no case of polio. So I think better governance, the way that routine immunization and polio have been delinked. मैं लेडी हेल्थ वर्कर हूँ, एक तो आपकी कवरेज कम है ना, लेडी हेल्थ वर्कर कवरेज रिपोर्टेड कवरेज इज 48, बट एक्चुअल कवरेज मस्ट बी 35%. I can go into details around each province. So I talk to I talk to people. Why is polio resurging? There's a whole polio economy around it. It's very deep. अभी भी अगर आप सुने, one of the regions जहाँ कुछ polio workers fire हुए हैं, so they said हम if you do not give us back our jobs, we will let polio be like this. So मैं एक ही program है. So immunization का आपको पता है एक ही program था पहले, routine immunization. So you had measles, you had everything. And then money went into the system. You said polio करोगे तो additional पैसा मिलेगा, और वो additional पैसा is double than that जो तनख्वाह वो ले रहे हैं. So what will I do? As a human being, I will try to work more on a certain thing that has been incentivized better. And polio, by the way, is not run by the provinces alone. There's a lot of donor community that finances polio. Okay? And it is not on your budget. It's an off-budget support. So not going in details into polio, I would not, as a practitioner in my whatever capacity, would ask the government go back and have their programs run by the federal government, which is, हम तो वहाँ abolish कर रहे हैं वो ministry शायद in its archaic way because it's not working. I was in the federal government's ombudsman committee. आप ICT में आप वो 4 अस्पताल ठीक कर देना बड़ी बात है. You go to ICT. ICT is like 2 million people, right? Have you seen the healthcare there? If they cannot take care of the healthcare there in ICT, I don't think they can take care of what the provinces are doing. So that's your first. I'll just go through and then you can answer. Madam, thank you so much. Good to have you here. So health literacy, we are very poor. And you're actually right. जब तक आपकी female empowered नहीं होगी, female literate नहीं होगी, and there's a causal relationship between the two. So you already know that. Mental health, the new UHC benefits package has mental health. It is not being implemented. There are mental health programs to be instituted. I am doing the world's first UHC benefits case implementation in Tandualayar in Sindh. We're trying to see. And सबसे पहले जो गवर्नमेंट ने कहा है जी हमारे पास पैसे नहीं है. देखिए हमेशा it comes, वो कहते हैं कि हम ये दवाई दें, हम माँ को maternal mortality पे काम करें. These are policy, although mental health is equally important, okay? But it's in the package, but they said that they would like to prioritize the 68 rather than the 113-degree package. और रश की बात कर रहे हैं, रश को खत्म करने के लिए rocket science नहीं चाहिए. You don't need that. Why can't we does any of the province have an urban primary healthcare model? No, there's no urban primary healthcare model. अगर मैं किसी urban primary healthcare filter clinics में जाऊं, I cannot be seen in Mayo or any other hospital unless I'm referred. Those are missing. Those referral systems are missing. Even सेहत सहूलत में अगर हमने ये कहा होता, anybody who bypasses, एक तो PHC है ही नहीं सेहत सहूलत में, अगर आप bypass करेंगे, which other countries do, you want to bypass the primary healthcare system and go to a tertiary care, you pay money. So you pay $20 or $50. One, you will not be referred in countries, some of the models, you have to pay a fee. Okay, you have bypass, so pay. So it's your wish. तीसरी चीज थी आपकी, so you need to, my point is that you need to come with very strong, comprehensive urban primary healthcare systems, which currently some are piloting. देखिए, pilots are always successful. I haven't seen any pilot fail. I'm not an optimist. I was at that optimistic stage. Now I am a hopeful pessimist. It's another term that I've come up with, a hopeful pessimist, because of various things and seeing the whole thing going. I don't agree that the government is doing excellent, but I'm saying कुछ governments कुछ ठीक किया है, कुछ गलत किया है, और वो हर सेक्टर में आपको ऐसे ही लगेगा. हमें क्यों अब याद आया कि PI प्राइवेटाइज करना है? There's no rocket science around it. Anyways. Thank you so much, sir. Sehat card. So I practically work in other countries, like Indonesia has the largest health insurance program in the world. It's the largest after India. So we work in Indonesia also. My company and I advise my country teams in Indonesia. So Sehat card, I am a STEM person, so I go on what the results have been. Sehat card की AKU ने अभी third party validation की है. So we should, as scientific people, as STEM people, we should not justify cases 1, 2, 3. आप किसी भी health insurance scheme में around the world देखेंगे ये gaming होती है. There will be gaming. We give a margin of 4 to 5%. It varies different countries. I'm not talking. बट फॉर केपी सेहत कार्ड अभी आप नेशनल हेल्थ अकाउंट्स चेक करें, आप थर्ड पार्टी वैलिडेशन बाय AKU करें, the out of pocket expenditures, the catastrophic health expenditures have gone down. अब वो अलहदा बात है कितने पैसे आपने खर्चे, उनके क्या इश्यूज है, अभी भी उनको पैसों के इश्यूज हैं. I myself have issues on the model itself. So I'll give you an example. We have a public funding pool. ये आपके सारे public sector facilities. फिर आपके आर्मी facilities है, आर्मी pool. Then you have social welfare. Then you have PESI. And then you have sehat sahulat. मैं आपको pools की बात कर रही हूँ और इसमें बहुत ज्यादा और भी होंगे. And then you have, civil servants pool. Sir, आपकी जब तनख्वाह लगती है, I have never been a government servant. I was directly inducted in grade 21, first time in the history of the province, I think, in the planning department because they wanted technical people. Sir, अगर आपकी तनख्वाह देखे गवर्नमेंट के लोगों की, में से हेल्थ अलाउंस होता है, ठीक है? So मैंने आपको मोटे मोटे 8 pool बता दिए. So as an army person, I can go to Mayo for free. As a Mayo person, I can go to Social Security. You as a government officer will have health allowance, but you're still taking other services free. सबसे पहले तो इस pooling को ठीक करना. You have to have a single national pool. That's what Indonesia did. That's what Turkey did. ये different pool से आपके पैसे, so it's more about efficiency rather than money for me right now. Bangladesh spends less than you. Our spending is less than 3% of GDP. They spend even less. Their indicators are far better than us. Why? There is a game of efficiency. Okay? So try to curtail down the pools. Sehat Sahulat. I started, Sehat Sahulat started very long back. I was member of the planning board. We had to implement it in 17 districts. It started the way green card started in Turkey. कि सबसे जो below poverty line लोग हैं, उनको एक सोशल प्रोटेक्शन दे दो. बिल्कुल ठीक है, डेटा ठीक नहीं था बिस का, वो ठीक कर सकते थे, आपने NSER नया ठीक कर सकते थे, और उनको एक टारगेटेड सब्सिडी आपने दी और उनको केटर किया. Suddenly, because of political sloganeering, whatever, you came up with this model that ab sabko hoga. Did you see your finances? Did you see your pools? Did you see your strategic purchasing? Did you see your institutions running Sehat Sahulat? 3 people in KP, a company here, 4 people. Balochistan ne ab start kiya hai. Gilgit-Baltistan has started. Sindh ki Madam Minister ne kaha, I'm not starting it. So, ये नहीं कि politicians को हमने उस वक्त advise नहीं किया. They did not want to listen at that time because it was more political. It's not that it's not doable. अभी वो चल रहा है. It's not a bad program. We are not saying it's bad. I'm saying it's not sustainable. Uske gains itne nahi aa sakte because every day there is an issue. So you need to be very strategic in designing programs and take technical people on board. Not just कि मैं सबको दे दूंगा, वो हम नहीं नारे लगाते हैं, हम सबको दे देंगे. पहले आप दी देखें आपके पास पैसे कितने हैं. If you have 100 rupees, just spend 100 rupees. Don't promise. वो कहते हैं don't over-promise and under-deliver. So that is something that we've been advising the governments. Sometimes they take our advice, sometimes they don't, and that's the beauty of governments around the world.
So I'll just answer your question. I think you're spot on. And I think you've highlighted a space where historically tech's done really well. The Mom Connect example that I gave you, that is an educational program, right? So it's something that handholds you through your pregnancy and through your, it'll tell you, okay, third month birth, this is how much your child should weigh. This is what their diet should look like, things like that. I think that we've done some of these trials in this country as well, where they've worked phenomenally well. So if you look at sort of baseline service, say data, and end-line service, say post-trial run, there's a significant difference in increase in knowledge, and that often translates directly into better pregnancy outcomes, but also better child health. I think that's what we're doing. So what we're doing with Lady Wellington is building WhatsApp-based patient-centric systems, jahan par they can ask their questions on WhatsApp. The reason we're doing this over WhatsApp and the reason there is such a need for systems like this is because when we've spoken to women about where they're getting their knowledge from, आपने intergenerational की बात की, we've spoken to hundreds of women कि आप about your own intimate health, about your own pregnancies and where you're getting this knowledge from. very few मेरी अम्मी ने जो कह दिया, अम्मी से बात की मेरी अम्मी ने कहा, but often there are myths that are passed down generation to generation, right? So when we've spoken to women about this, one of the things they've said, and it was quite horrifying actually, is that, oh, sort of I went on YouTube and then I looked at this video and it told me to do XYZ and I did it and then I had a miscarriage. Right? Because there is this understanding amongst a vast percentage of your population कि अगर कोई चीज़ internet पर पड़ी है, that is the equivalent of it being in a newspaper. It has been vetted. It is accurate information, right? So this idea that what you have online might not be true is just missing. And so you want curated systems that give you sort of back end, but the content is curated, right? It's fact checked. आपने mental health की बात की. We did an extensive study with lady health workers to understand कि जब वो counseling करती हैं pregnant औरतों की, there's sort of the first line of defense, right? What are they telling them about postpartum depression? That's what we were interested in. All the lady health workers we spoke to said कि हाँ उनको वो चिड़चिड़ी होती हैं, हम उनको कहते हैं ये चिड़चिड़ा होना normal है, खुद ही ठीक हो जाएगा. That's the extent of the counseling they can do. So I think if we want to really, I mean, I really hesitate to put anything on lady health workers because I think in this country it was a program that did so well, so we started dumping everything on them. हम सब कुछ उन पर डाल देते हैं कि ये first line of defense है, ये कर देंगे. But I do know Khan is running some trials. They're sort of a tech mediated through lady health workers to tackle post and prepartum depression amongst women. So I know that they're running these, their psychiatry department is running these trials, and my understanding is they're very successful because you're sort of upskilling lady health workers to do that work.
Just for the information, the lady health workers were hired in 1990s. वो बेचारे अब, we did a retirement analysis, we did a financial analysis. We're working now in 3 provinces on lady health workers because जब वो institute हुए थे, Maryam is right, they were instituted कि वो family planning services करें. फिर हमने कहा ये तो जा ही रही है घर, ये nutrition भी कर ले. अच्छा ये जा रही है, ये commodities भी दे दे. अच्छा ये जा रही है, ये polio भी कर ले. So they are doing like 100 things and not doing anything at the end of the day. They are not tech savvy because they're about to, I think the last will retire in 2050. That's the last one. But वो अभी इस age में नहीं है. ना उनकी पढ़ाई इतनी है, 5वीं जमात, no tech savvy. How are they going to do things? So that's why we're trying to do new pilots. We're trying to tell the government in Sindh, for example, it's very, very mature, that please, you don't need to, so Lady Health Workers was instituted by PPP government. They're not even ready to change the name because it was Mohtarma's name, so we couldn't do it. So now we have known them, we've called them CHWs, Community Health Workers, and they will be piloted by private sector. They will do a certain set of services and they will be paid for those services. Punjab is doing a very different model, pay for performance. Pay for performance. It's like you do one thing and you just get paid 20 rupees, you do this service. KP government, very low coverage, especially all over. So we're also trying to do something that fits. So just on that caveat, community health workers are a linchpin, but unfortunately they have not taken up the way. They did exceptionally well in the first 10 years or a decade or two. But now the program is dwindling, their financing is just the aap unko tankhaein de rahe hain, and they're not working because they are civil servants.
I think we've run out of time, so I'm very sorry I cannot take any more questions. I just want to say thank you to my 2 panelists. I mean, for me, this has been a fascinating discussion, and I think at some level where maybe we are moving towards a kind of understanding of what is better needed in our country when it comes to public health, looking at strengthening the health systems and looking at actually rethinking some of the very good policy ideas that have been implemented, but the need for change, the need for constant innovation and review, and the need for proper monitoring, I think, is what really I have been left with. But once again, Maryam and Shabana, thank you very much. I hope the audience was enlightened as well. So thank you all.